imagine when adrenaline comes and they bind to alpha, beta receptors, you are going to get all these effects. So please, as a way, when you get your notes, revise, and I've made it a bit simpler for you, so that you know beta 1 what is going to happen, alpha 1 what is going to happen, beta 2 what is going to happen. But the summary is what I give you. Alpha 1 receptors on the lungs causing what? Alpha 1 receptors on the blood vessel causing what? Vasoconstriction. Beta 2 on the lungs causing what? Bronchial dilation. Beta 1 on the heart increasing what? Heart rate. And alpha 2, when you stimulate alpha 2, it inhibits what? The release of what? Norepinephrine. And when you inhibit the release of norepinephrine, then it means circulating norepinephrine will go down, then you wouldn't have vasoconstriction. So we use alpha 2 to really manage hypertension, mostly in what? Pregnant women. Let's look at some clinical uses. We can use alpha 1 agent to control what? Hypotension. Who can help me out? Now we are saying that when someone is having hypotension and the person comes to the hospital, we can use alpha 1 drugs to control hypotension. And if I should ask of the rationale, can you tell me, when the person is having hypotension, you want to increase the blood pressure. And one way of increasing the pressure is what? By causing what? Vasoconstriction. And we said alpha 1 receptors are found where? On the smooth muscle, that causes what? Vasoconstriction. So if a drug can be given that will constrict your vessels, then it means what? Your blood pressure will start what? Increasing. Because once your vessels are constricted, their heart will be pumping with so much force. And as the heart pumps with so much force, it increases what? Its pressure. So the heart rate goes up. And that can increase what? Your blood pressure. Then you can also use it to treat what? Nasal congestion. When your vessels dilate, there's a lot of blood supply. Some seeps, then you have running nose. So the nasal drug that we are using, we give and it constricts the blood vessels, limiting the amount of what? Blood flow to your nasal region. And that solves nasal congestion and red eye. Red eye, dilation of blood vessels on the eyes will cause for red eye. So when we constrict the vessels on the eye, it decreases what? Blood supply, and that will take care of what? Your red eyes. Then another application worth noting is the use of this drug as what? A vasoconstrictor. Sometimes this local anesthesia, it comes with other epinephrine. And why does it come with it? Because we want the drug, the action of the drug to be prolonged. We add epinephrine. So epinephrine will constrict that blood vessels, and that will limit what? Absorption of the drug. So the drug will stay at that place for a very long time, prolonging what? The action of what? The drug. So we add epinephrine to this local anesthesia just to prolong the action of the drug, and also to produce what? A bloodless field, or limit the amount of what? Blood oozing from what? The blood vessels. So these are some uses of alpha 1 drugs. Let's move on to some other uses of alpha 1 drugs. So this was alpha 1 agent. And I said alpha 2. When you stimulate alpha 2, what is going to happen? Alpha 2 will cause what? Less norepinephrine to be released. They are going to inhibit norepinephrine. And if norepinephrine release is inhibited, then it means your vessels will be what? Dilated. Because when norepinephrine binds to alpha 1 receptor, vessel was constriction. If you don't have a lot of norepinephrine in circulation, then your vessel will be what? Constricting. So we use this agent to even reduce BP. And in the world, those of you on the world, I know that you know this agent, metadopa or clonidine. Metadopa is mostly used a lot in the hospital. It is also known as what? Ardomate. Metadopa or ardomate. We use it a lot in the hospital. They are what? Alpha 2 what? Agent. They bind to the alpha 2 receptors and they inhibit what? The release of what? Norepinephrine. I know you've come across this drug in the hospital to be for clonidine. Clonidine 2 is an example of what? An alpha 2 what? Agent. So if you want to know what alpha 2 will do, this diagram will give you a nice sample of what? Alpha 2. So alpha 2 So this is alpha. So alpha 1, what the alpha 1 will do, then alpha 2. So mechanism of action of beta 1 adrenergic drug. So beta 1, I said beta 1 can be found where? On the heart. And on the heart, what will beta 1 do? When you activate beta 1 receptors on the heart, it causes what? An increase in heart rate. So this means that beta 1 receptors can cause your heart rate to what? Increase. So they increase heart rate and they also increase force of contraction of the heart. Aside them increasing the heart rate, they increase the force at which the heart used to what? Pump. So they increase heart rate and also increase the force of what? Contraction. The increased cardiac output that ensues can lead to an elevation in blood pressure. So when someone comes to the hospital and you give the person adrenaline, especially with the person with a low BP, you give the person adrenaline and the BP comes out, what really went on is adrenaline went to bind to alpha 1 receptors. That causes what? Vasoconstriction. Then they also came and activated what? Beta 1 receptors on the heart. And that one also what? Increased the heart rate. So with time, the person BP what? Normalized. These are really okay. So beta 1 receptors on the heart will cause what? An increase in heart rate. So they will increase heart rate and they will also increase the force of contraction of the heart. That's the most important thing that I want you to know over here. Even though we didn't go through a lot of processes, but before the heart rate would be what? Will increase, there are a lot of chemical signals. So like beta 1 receptors will bind to beta 1 drugs will bind to a receptor. And we say receptors, they are proteins. When it allows a ligand to bind to and activate to cause an effect. So when beta 1 receptors bind to a beta 1 drug bind to a receptor, so many chemical messages goes on. Even though we didn't go through all these chemical messages, but so many chemical messages will go on that will now enable your heart rate to increase. Now you get the contractions and all what you are looking for. Because at the point you get the cause of influx of calcium, and you know what calcium too will come and also what do. Although you didn't go through this process because somehow cumbersome at this level, you don't need this at this level. So just know that beta 1 receptors will what? Cause an increase in what? Heart rate. Beta 1 receptors will cause an increase in what? Heart rate. And if they are causing an increase in heart rate, then we can use this to manage people whose heart is what? Failing. So clinical application of beta 1 receptors. Let's look at some clinical application of beta 1 receptors. I don't know whether you've come across this drug, dobutamine, in the hospital before. Dobutamine. Dobutamine is a selective beta 1 drug. When you say selective, that drug is just going to bind to what? Only beta 1 what? Receptors. So clinical application of beta 1 stimulation are what? Positive inotropic agents. So they help the body to what? Or they help the heart to contract more, or they cause influx of calcium that will enable the heart to also what? Pump more. So dobutamine is an example of a beta selective drug. So dobutamine or what? Isoprenaline. These are beta agents. What do they do? This drug will come and cause what? An increase in your heart rate. So as this drug increase the cardiac workload and output, the patient must be monitored closely. But you are giving a drug that is going to stimulate the heart to work well, because the heart is failing and you want the heart to be revived. So you are giving a drug that will revive the heart to work. So if you are going to use that drug, then you have to monitor your patient closely, because then that means the heart can also beat faster. So you have to be monitored for what? Arrhythmias and other what? Complications. And so the patient will have to be at the intensive care unit so that you keep what? Monitoring the patient daily. So beta 1, these are all what beta 1 is going to do. So on the heart, they cause increase in heart rate, and they also cause what? Increase in the force of contraction. And that will lead to what? Increased cardiac output, and will increase blood pressure, and will lead to what? Hypertension. So on the kidneys they stimulate the release of what? Renin. And renin will come and start the renin angiotensin-aldosterone system, and that will lead to increased BP and what? Hypertension. On the adipose tissue, they increase blood lipid levels. Then on the GIT, they decrease what? Peristalsis, that can lead to what? Constipation. So when you have this diagram, it can just tell you where you can find beta 1 receptors and exactly what they are going to do for us. Okay, so mechanism of action of beta-2 receptors. Beta-2 receptors. The mechanism of action of beta-2 receptors. So we are done with beta-1. So we are going to look at what beta-2 receptors. So we are done with the beta-1 receptors. I said, so with the beta-1, when you look at this diagram or the flow chart over here, where you can find beta-1 receptors, and when you stimulate those receptors, what is going to happen? So on the kidneys, they are going to release renin, and renin will come and start the renin and angiotensin aldosterone system. That will lead to increase in your BP, and you have hypertension. On the heart, they are going to increase the rate of the heart, and you are also going to increase the force of contraction of the heart. This will increase the cardiac output, and due to what you have an high BP. Then on the GIT, these are the effects. So now let's move to beta-2. Beta-2, I said beta-2 receptors can be found on the bronchioles, not only the bronchioles, so they can be found on the bronchioles, they can be found on the uterus and other places. But on the bronchioles, when you stimulate beta-2 receptors, what is going to happen? They help our bronchioles to dilate. That means the bronchial muscles will be relaxed. A lot of inhaling can be breathing a lot of air. So what is the clinical application? When someone comes to the hospital and those people are like someone having asthma. Asthma is mostly due to what concentration of the muscles, and when they are able, they use all their accessory muscles. So their muscles set into spasm. So they come and give them salbutamol, maybe inhaler or nebulizer. Give them maybe a nebulizer. And this and feel their what happened? The drug went to activate beta-2 receptor. They said when you activate the beta-2 receptor, what is going to happen? The beta-2 receptor will cause what? Bronchial dilation. So when you stimulate the beta-2 receptors, the bronchioles will now dilate. So that's one clinical application. You can use it for the management of what we call asthma, especially the attacks, the acute attack. When someone is having acute asthmatic attacks, they come, you give them the nebulizers or the inhalers and they are work, because the drug will go and activate the beta-2 receptors, and that will also dilate the bronchioles. Another usage of the beta-2 receptors is that we can also use it in labor. When someone has threatened abortion, maybe the person wants to keep the baby and they didn't want to come out. We know that it's the contraction that brings about the baby. So when the uterine muscle contract and relax, so once they are contracting, it's pushing the baby out. Beta-2 receptors, I said, they are found on smooth muscles, and they cause relaxation of the uterus. So the person comes to the world and maybe they give terbutaline. We give this drug, and this drug can cause relaxation of the uterine muscles. So once the uterine muscles are relaxed and they are not contracting, then you can keep the baby. So these are some clinical considerations of the beta-2 agents. So you can just read this for yourself. Now we are going to submit the beta-2 on the bronchioles. This is what they are going to do. They dilate the bronchioles on the skeletal muscle. So this is just a summary of everything that we have said over there. So you look at this diagram, and that one will even give you a lot of ideas. So I brought this flow chart to help you out. Now let's move to, as I said, so the uses. So we've talked about almost all these uses. So terbutaline can be used to delay premature labor. You can use it to delay premature labor, even though it can also be used to reverse bronchospasm, but can also be used to delay premature labor. So these are some drugs earlier used. So please, I want you to go through this for yourself. And let's move to antagonists. We know what antagonist is. He said agonists interact with the receptor and activate the receptor. So agonists will go and help the receptor or help in activating the receptor. And antagonists are drugs that bind to the receptor but do not activate the receptor. Antagonists, they are drugs that bind to the receptor but do not activate the receptor. So now let's look at some antagonists. We are going to look at alpha antagonists and beta antagonists. So what is the uses of alpha antagonists? We said alpha 1. Alpha 1 will cause vasoconstriction. So it means alpha 1 will help your blood vessels to constrict. And if we are blocking, so alpha 1, so let's say when adrenaline comes and activates alpha 1, it will cause your blood vessels to constrict. So the blood vessels will be narrowed. That is this. But when we prevent, okay, so let's look at clinical uses of alpha 1 antagonists. So alpha 1 antagonists. So the question I asked was, what is the main use of, what is the function of the alpha 1 receptor? When you activate the alpha 1 receptor, what happens? So when you activate the alpha 1 receptor, so when adrenaline comes and activates the alpha 1 receptor, we are going to get vasoconstriction. So this means that when you activate the alpha 1 receptor, your blood vessels are going to be constricted. What happens when we prevent adrenaline from activating alpha 1? So if we come and block here and adrenaline does not come and activate, that means your vessels are going to dilate. So we have a drug called prazosin, doxazosin, terazosin. They are selective alpha 1 antagonists, and they are used to treat hypertension. So when someone comes to the hospital and the person is having hypertension, you can give a drug that will dilate the blood vessels. And how is the drug going to work? The drug is going to prevent adrenaline from activating alpha 1 receptors. So prazosin, terazosin, doxazosin, they are used to manage hypertension. And we can also use alpha 1 agents or alpha 1 blockers to manage benign prostatic hypertrophy. And this one, I want you to find out how that alpha 1 helps in managing benign prostatic hypertrophy. I will be happy for a response in the feedback. So please, I want a feedback. How does alpha 1 blocking agent, especially tamsulosin, helps in the management of benign prostatic hypertrophy? And please find out the meaning of this word. I'm not going to pronounce this word for anyone to laugh at home. Pheochromocytoma. Pheochromocytoma. Please find out the meaning. It's just a benign of the adrenal gland. So this means that someone with this tumor on the adrenal gland is going to secrete more adrenaline. And you know that when adrenaline comes, they are going to bind to alpha 1 receptor to cause vasoconstriction. And they can also bind to beta 1 receptors to also cause increase in heart rate. So when they are binding to alpha 1 receptor, they are going to get vasoconstriction. So when you have tumor on the adrenal gland and your body is synthesizing or secreting a lot of adrenaline, then we give you an alpha 1 agent, because when adrenaline comes, adrenaline will bind to alpha 1 receptors and cause vasoconstriction. But when we give you a drug that can block the alpha 1 receptors, then it means your vessels wouldn't be constricting. So an example of a drug that we use is phenoldibenzamin or phenoldibenzamin. We use this drug to manage what we call pheochromocytoma. Pheochromocytoma is a tumor in the adrenal gland that causes the adrenal gland to secrete a lot of adrenaline. And we know the effect of adrenaline. They are going to cause vasoconstriction, and they can also increase your heart rate. Then beta blockers. So I'm moving now to the beta blockers. I said beta 1 can be found on the heart. And on the heart, it causes an increase in heart rate. Then beta 2 can be found on the bronchioles. It causes bronchodilation. So we are going to look at beta blockers. So it means that we are going to now block the beta receptors. So if adrenaline comes, binds to the beta receptors, and your heart rate will go up. Then now, because maybe you have hypertension or you have some other condition, you don't want your heart rate to go up. So we can now come and block these beta receptors and prevent adrenaline from what activating the beta 1 what receptors. So beta 1 receptors, example of a beta 1 receptor, or what can we use beta 1 receptor to do? We can use beta 1 receptor to decrease heart rate. We can also use beta 1 receptor to manage blood pressure. So we can use it to decrease heart rate. And you know why? Because activating the beta receptors increases your heart rate. So when you are blocking the beta receptors, you are going to decrease heart rate. Then increase in heart rate will lead to increase in blood pressure. So as you are decreasing the heart rate, you are also going to decrease the blood pressure, and you are also going to still decrease plus like renin release and other things. So we are going to decrease heart rate. Then we are going to also decrease blood pressure. Then beta blockers can also be used to decrease intraocular pressure. So they can be used to manage glaucoma. Then beta blockers are dangerous in asthmatic patients. We said beta 2 receptors are found on the bronchioles and they cause bronchial dilation. So if you give a drug and the drug is going to stop the beta 2 receptors from working, then it means you're going to cause constriction. We said beta 2 receptors will cause bronchial dilation. This means that if you activate beta 2 receptors, or when adrenaline binds to beta 2 receptors, your bronchioles will dilate. But if you give a drug that will prevent the beta 2 from being activated, or that means that you are blocking the effect of adrenaline on the beta 2. So it means the beta 2, when you activate them, then your bronchioles will dilate. But when you block them, your bronchioles are going to constrict. So it is very dangerous to give a beta 2 agent to asthmatic patients because it can trigger the asthmatic attack. So these are some uses of beta agents. We are going to be looking at it in antihypertensive, so I wouldn't spend my time over here. These are some uses of beta 2 agents. And this brings us to the end of adrenergic pharmacology. We will end here. Then our next video will be on antihypertensive. We will talk about the autonomic pharmacology later. Our next video will be on antihypertensive. Thank you.